For decades, we've treated hormone replacement therapy or HRT kind of like a parking meter.
Oh,
Like
absolutely.
you put your coins in, you get a set amount of time to park in this, menopause relief zone, and you're just constantly checking your watch.
Right, because everyone tells you that the second that meter hits 5 years, time is up.
Exactly. And if you don't pull out of the space immediately, you're going to get hit with this massive penalty.
There's this looming, invisible deadline that just creates an immense amount of anxiety for so many people. And the fascinating thing is really how deeply ingrained that fear has become, not just for women, but like within the medical community itself.
Yeah, which is why today we're taking a deep dive into a massive stack of modern medical sources to figure out where that fear actually comes from and, what the science actually says today.
We've got a lot of ground to cover.
We really do. We are looking at updated guidelines from the National Institute for Health and Care Excellence, NICE, along with the British Menopause Society. Plus, we have clinical studies from Goldman Labs and some NHS practice standards.
It's a really comprehensive set of data.
Right. And the mission for this deep dive is to help you, the listener, cut through all those outdated myths. We want you to understand the actual evidence-based calculus of taking, maintaining, and eventually stopping HRT.
Because it turns out that whole parking meter analogy, it's completely wrong.
Okay, let's unpack this. Because for years, people treated HRT like that meter running out, but the modern medical consensus paints a very different picture.
It really does. But to understand why we have this 5-year myth in the first place, we have to talk about the historical elephant in the room.
Oh, the 2002 study.
Yes, the 2002 Women's Health Initiative, or WHI study. The interpretation of this one single event, it completely altered the trajectory of women's health for an entire generation.
Because 2002, it doesn't sound that long ago, but in medical science, it's basically a lifetime. What exactly happened with this study that caused such a massive ripple effect?
Well, early reports from the WHI study seem to show a sudden increased risk of breast cancer and heart disease for women on combined HRT.
Wow.
Yeah, and the media coverage was just explosive. It created this widespread panic, and as a direct result, HRT usage plummeted by a staggering 66%.
That is huge. So millions of women just abandoned a highly effective treatment practically overnight.
Exactly. But later long-term follow-ups and reevaluations of that very same data showed that the initial panic lacked some really vital context.
Like what?
Well, the researchers had largely studied women who were in their mid-60s and 70s, and many of them already had undetected cardiovascular plaque buildup.
Wait, so they were studying women who were a decade or more past the onset of menopause?
Right. The initial data didn't separate the age groups properly at all, so applying the risks of a 70-year-old starting oral HRT for the very first time to, say, a newly menopausal 50-year-old, it created a false equivalent.
Oh, I see.
For the older women with that existing plaque, oral estrogen could sometimes cause the plaque to destabilize. But for women in their 50s starting HRT, it was actually showing a protective effect on the heart.
So the nuance was completely lost in the headlines, basically.
Entirely lost. The risks were vastly overstated for the average woman, but that initial fear really shaped the 5-year limit myth that we still see persisting today.
I'm a little confused, though, because if I'm looking at current guidelines from NICE and the British Menopause Society, they explicitly state, and this is a direct quote from the source material, that there should be no arbitrary limits placed on the duration or age of a woman taking HRT.
That's right.
So if the guidelines say there's no time limit, why do so many women and even some doctors still push to stop after 3 to 5 years? Is it just that lingering fear from 2002?
A lot of it is, yeah. Institutional memory is incredibly hard to rewrite. Many practitioners trained during or just after that WHI fallout, so that extreme caution just became their baseline.
That makes sense.
Furthermore, it's a misunderstanding of how risk profiles shift over time. While the arbitrary limit is gone, the guidelines don't treat HRT as a lifetime free pass without any monitoring.
Right, you can't just take it and forget about it.
Exactly. The risk profile slowly shifts depending on how long you use it and the type of HRT you're on. With combined HRT, so that's estrogen paired with a progestogen, there's a small duration-dependent increase in the risk of breast cancer.
And because of that shifting math, I'm assuming that's why the guidelines strongly emphasize an annual review.
Yes, you and your doctor need to sit down every single year and recalculate the benefits versus the risks. It's not a one-and-done decision.
And there's a crucial exception we really need to highlight from the sources regarding early menopause, right? Like for women with premature ovarian insufficiency or POI, HRT isn't just about symptom relief at all.
No, it's completely different for them. For women who go through menopause early, well before the average age of 51, their bodies are missing out on years of essential protective hormones.
So they have to stay on it.
Guidelines strongly recommend staying on HRT, at least until that average age of natural menopause, around 51 in the UK. Their bodies desperately need that estrogen to protect bone density against osteoporosis and to maintain foundational heart health.
Wow, okay, so it is a completely different calculus for them.
Absolutely.
So to understand when to stop HRT, we first have to understand the modern rules for how long you can stay on it. And since there isn't a hard expiration date, the decision to stop usually comes down to this evolving calculus as a woman ages, especially as she crosses the threshold of age 60.
Timing's everything here. Starting HRT before age 60 or within 10 years of the onset of menopause has a highly favorable profile. Medical literature actually refers to this as the window of opportunity.
The window of opportunity, I like that.
Yeah, and data from Cochrane analyses and those long-term WHI follow-ups show that initiating HRT in this window actively reduces the risk of atherosclerosis, coronary heart disease, and all-cause mortality.
Because the estrogen helps keep blood vessels flexible and healthy.
Exactly. It's highly protective in that specific window.
But the sources note that natural menopause symptoms generally decline as women get older. So as you cross into your 60s, the primary benefit of HRT might be decreasing for some women, while certain risks slowly creep up.
Right. And this is where we really have to contextualize the breast cancer risk, because it is consistently the biggest fear women bring into the clinic.
Oh, for sure.
The British Menopause Society notes something really striking here. Being overweight or obese, or drinking 2 or more units of alcohol a day, actually carries a greater risk for breast cancer than 5 years of combined HRT.
Wait, seriously, that is wild to think about. 2 glasses of wine a day is statistically riskier than the hormone therapy people are terrified of.
It is. It really forces us to put statistical risk into perspective, you know. And beyond lifestyle factors, the risk depends heavily on the type of HRT.
Right, because there's combined and then there's estrogen only.
Exactly. Estrogen-only HRT, which is typically given to women who have had a hysterectomy, is associated with little to no change in breast cancer risk.
Oh, wow.
In fact, the long-term WHI data showed a small decrease in breast cancer diagnosis and mortality for the estrogen-only group.
So the slightly increased risk we always hear about is primarily associated with combined HRT.
Yes, specifically how the synthetic progestogen component interacts with breast tissue over really long periods.
Okay, so let's say a woman is crossing that age 60 threshold. She still has hot flashes, her quality of life is way better on the medication, and she wants to stay on it.
Okay.
The guidelines suggest she doesn't necessarily have to stop, but she should probably change her delivery method, right? Like lowering the dose and switching to transdermal estrogen-like patches or gels rather than oral tablets.
Yes, and there is a fascinating physiological mechanism behind this recommendation. When you swallow an estrogen pill, it travels to your stomach and then goes straight to your liver for processing.
The first pass metabolism thing.
Exactly. This oral route triggers the liver to produce excess clotting factors as a byproduct, which slightly elevates the risk of venous thromboembolism, so blood clots and stroke.
But transdermal is different.
Very different. When you use a transdermal patch, spray, or gel, the estrogen is absorbed directly through the skin into the capillary beds and the broader bloodstream.
So it bypasses the liver entirely.
Exactly. By skipping that first pass liver metabolism, transdermal estrogen does not increase the risk of blood clots or stroke above the baseline population risk.
That is such an important distinction.
It really is. Because as women age and their baseline cardiovascular risks naturally increase, removing any extra unnecessary risk from oral medications becomes a huge priority.
So it's kind of like driving a car as the weather changes. You don't necessarily have to pull over and stop driving altogether just because you turn 60 and winter arrives, but you do need to change your tires.
I love that analogy.
You switch from oral pills to a transdermal patch to ensure the journey stays safe under the new, icier conditions.
That captures the ethos of modern guidelines perfectly. Menopause isn't a deficiency disease to be cured forever with high doses of hormones. It is a natural life stage.
Right.
The goal of HRT is dynamic symptom management, always seeking the lowest effective dose for your current stage of life.
So if switching to transdermal patches buys us more time safely, what happens when a woman and her doctor ultimately decide it is time to stop? Maybe she's tired of the daily routine or she's experiencing unscheduled bleeding. How does she actually do it?
Well, the sources are very clear about what not to do. The absolute biggest mistake is stopping cold turkey.
Because of the crash. One clinical study from the sources noted that 75% of women who stopped abruptly had a return of vasomotor symptoms within just 2 weeks.
Yes, 75%. It causes a massive shock to the system. Your body has been relying on this steady, supplemental stream of estrogen, and suddenly the well just runs dry.
And what does that rebound look like?
It's severe. We see intense hot flashes, night sweats, joint pain, sleep disruption, anxiety, and just really intense mood swings.
So pulling the Band-Aid off fast is a bad idea. The alternative is tapering then.
Yes, the medical consensus across the NHS and BMS guidelines strongly favors a gradual reduction over 3 to 6 months.
How does that usually work in practice?
They typically suggest cutting the dose by a quarter or a half every 2 to 4 weeks, just easing the body down.
But here's where it gets really interesting to me. The NICE guidelines note that in the long term, whether you taper for 6 months or quit cold turkey today, it makes absolutely no difference in whether your menopausal symptoms permanently return.
That's correct. The final physiological destination is indeed the exact same.
Wait, so if my hot flashes are destined to come back anyway, why draw the process out for half a year? Isn't it better to just get the suffering over with?
I get why you'd think that, but hormonally, it's much more complex than a quick sting. The underlying physiology is all about preserving bodily equilibrium.
Okay, break that down for me.
Well, estrogen plays a massive role in regulating the hypothalamus, which basically acts as your body's internal thermostat. When estrogen levels are stable, your thermostat has a nice, wide comfort zone.
But when you drop it abruptly,
The hypothalamus narrows that comfort zone dramatically. The slightest change in your core temperature makes the brain think you are overheating, which triggers a massive sweating and flushing response to cool you down.
so that's the hot flash.
Exactly. And estrogen also closely interacts with neurotransmitters like serotonin and dopamine, which regulate your mood.
So instead of killing the furnace in the dead of winter and letting the pipes freeze overnight, you're just turning the dial down 1 degree a week so the house can adapt.
That is a much more accurate way to look at it. If you drop the estrogen to zero overnight, the hypothalamus panics, and your neurotransmitters get thrown into chaos, causing all that anxiety and depression. By tapering over 3 to 6 months, you give the hypothalamus and your brain chemistry time to gently recalibrate to a lower estrogen environment. You aren't necessarily changing the final destination, but you are preventing a violent disruptive shock to the system.
Tapering is entirely about preserving your mental health and quality of life during the transition then.
Precisely.
Okay, so let's say the taper is finished. You've slowly turned down the thermostat over 6 months. The HRT is gone. What happens next? Does the listener just have to suffer? Because the numbers in the sources are a little daunting.
They are. Around 40 to 50% of women experience returning menopausal symptoms when stopping.
That is a really high number.
It is, which is why setting realistic expectations is crucial. Symptoms usually peak around 2 to 4 weeks after the final dose and begin to stabilize within 3 months.
So 3 months is the magic window.
Yes, and there is a critical distinction you need to make during this period. Are these temporary withdrawal symptoms from the hormone drop, or are these underlying menopausal symptoms that the HRT was successfully suppressing all along?
How do you even tell the difference? They feel exactly the same, don't they?
They do, which means time is the only reliable indicator. If the symptoms are just withdrawal, as your body adjusts to its new normal, they should steadily improve and fade within that 3-month window.
And if they don't?
If you hit the 3-month mark and the hot flashes, the joint pain, the sleep disruption are still severely impacting your life, it's highly likely that your underlying menopausal symptoms have simply returned.
So essentially, the HRT wasn't curing the menopause, it was just holding the symptoms at bay. Which means stopping HRT is really just an experiment to see what your natural baseline looks like today.
It's an exploratory mission, exactly. And because of this reality, the data shows that over 25% of women who stop HRT end up restarting it within the first year.
So what does this all mean for you, the listener? I think it means stopping isn't a failure. If you try to come off and you feel terrible after 3 months, you can just go back on. I feel like a lot of people think if they give it 3 months and they're miserable, they've somehow failed at navigating menopause naturally.
Not at all. Restarting is perfectly safe, and it's very common. The guidelines just suggest that if you've been off it for a while, you should start back at a lower dose to let your body acclimate again.
That makes sense.
It's also highly recommended to keep a symptom journal during the weaning phase and the months after. Track your hot flashes, your mood, your sleep.
So you have actual data.
Right. That way, when you go back to your doctor, you aren't just saying, I feel bad.
Oh.
You have concrete, data-driven conversations about whether to stay off, restart at a lower dose, or explore alternative treatments.
Okay, there is one major exception to all of this stopping and tapering that we absolutely have to cover. We've been talking about systemic symptoms like hot flashes, night sweats, mood, but what about genitourinary symptoms?
Or the vaginal exception.
Right, vaginal dryness, pain during sex, urinary frequency. Do those eventually fade away like hot flashes sometimes do?
Unfortunately, they follow a very different trajectory. While systemic symptoms often burn themselves out over time, genitourinary symptoms of menopause are typically progressive.
Meaning they get worse.
They tend to persist, or even worsen forever if left untreated. The tissues in the vagina and urinary tract have a very high density of estrogen receptors. They depend on that hormone to remain plump, elastic, and acidic.
And without it.
Without it, the tissues thin out, the pH rises, and harmful bacteria can thrive, leading to constant UTIs and discomfort.
So if someone is stopping systemic HRT because they're older and worried about broader cardiovascular or breast cancer risks, do they just have to suffer through the vaginal symptoms?
Not at all. Women can and should continue using localized vaginal estrogen indefinitely. This comes in the form of creams, pessaries, or vaginal rings.
But doesn't that carry the same systemic risks we just talked about?
No, and that's the beauty of it. Localized vaginal estrogen is absorbed almost exclusively into the local tissues of the pelvis. It has minimal to virtually zero systemic absorption into the broader bloodstream.
Wow, okay.
Because it stays local, it does not require you to take a progestogen to protect your uterine lining, and the data shows it carries no increased risk of breast cancer, blood clots, or cardiovascular issues.
So you can use it safely for the rest of your life, even if you've completely stopped your systemic patches or pills.
Exactly.
It's like you can stop watering the whole lawn, but you can still safely water the one flower bed that really needs it.
That is spot on. It is a targeted therapy with an incredibly high safety profile. It solves a massive quality of life issue without adding to the broader risk calculus.
We have covered a massive amount of ground today. Let's do a rapid-fire recap. First, the 5-year limit is a myth. It was born from the panicked misinterpretation of that 2002 WHI study, which wrongfully applied the risks of 70-year-olds to women in their 50s.
Right. There's no arbitrary deadline. You can stay on HRT as long as the benefits of symptom relief outweigh the risks to your health.
Second, the calculus does change as you age. While starting before 60 offers cardiovascular protection, staying on past 60 usually means an annual review and a shift in strategy.
Yes, you should aim for the lowest effective dose and strongly consider changing your tires to transdermal patches or gels to bypass the liver and protect against blood clots.
Third, when you and your doctor decide it is time to stop, do not shut off the furnace overnight. Ease off the gas by tapering your dose over 3 to 6 months to give your hypothalamus time to adjust and avoid a violent hormonal crash.
And finally, expect a transition period. Up to half of women will see symptoms return, and a quarter will go back on HRT within a year. Track your symptoms. Give it 3 months to differentiate between withdrawal and underlying menopause.
And remember that localized vaginal estrogen is an exception that is safe to use for the long haul. Taking all these nuggets of insight to your next doctor's appointment is going to completely change the conversation you have about your care. But before we go, we always like to leave you with something to chew on.
This deep dive really brings up a broader issue. We've seen how the flawed early interpretation of a single study in 2002 caused millions of women to needlessly suffer by abandoning their HRT abruptly out of sheer panic.
It's really tragic when you look back at it.
It is. And it raises an important question for you to mull over. In our modern era of viral health information, where a single headline can travel the globe in seconds, how do we distinguish between genuine medical caution and collective medical panic?
Oh, that's good.
Are there other areas of your health or choices you're making right now that are being dictated by the ghosts of outdated medical panics?
That is a phenomenal question. It really makes you wonder how many other parking meters were nervously watching, completely unaware that the city actually removed the time limits years ago. Thanks for joining us on this deep dive. Keep asking questions, keep challenging the arbitrary limits, and we will catch you next time.